Good evening, everybody. This is the lecture for the abdominal examination. The objectives, these are the objectives that you should be able to do once you finish reading your Rhodes and Peterson chapter. Once you do all the YouTube videos, look at all the PowerPoints and articles. So you should be able to demonstrate knowledge and application of questions that inform the provider of differentials for common GI complaints. Demonstrate knowledge of genetic and lifestyle risk factors associated with GI problems. Demonstrate application of the descriptors associated with the GI history and physical exam findings. Characterize bowel sounds. Relate to different differential diagnoses. Identify aneurysms and renal artery stenosis through oscillatory and papillatory techniques. You'll be doing that in clinical. Quickly demonstrate light and deep palpation of the abdomen, which again you'll do a clinical. Assess for enlargement of liver, spleen, kidneys, and bladder, which is also your physical exam in clinical. Assess abdominal and flank pain and ascites. Assess for Murphy sign, psoas sign, and the Rosberg sign, and demonstrate the knowledge of physical exam findings associated with common GI differential diagnoses. So this is just a picture of the abdominal cavity, and as you look at it, you can see, it makes you realize all the organs that are in that one area. So the abdominal cavity is divided into four regions, four quadrants: the right upper quadrant, the left upper quadrant, and the right lower quadrant, and the left lower quadrant. And it's divided into three regions. So you have your epigastric region, which is above the umbilicus, the umbilical area, and the hypogastric or suprapubic, which are below the umbilical area. This is just the anatomy again of the abdomen. And when you do your abdominal exam, as you're doing each quadrant in each region, you want to really remember and think about what organs are in that area and are, that you have to really look at and palpate for. This is a chart. It's a really good chart about the abdominal organs within the quadrants. So, for example, in your right upper quadrant, you have the right lobe of the liver, you have the gallbladder, the duodenum, the head of the pancreas, the upper pole of the right kidney, the right adrenal gland, the hepatic flexure of the colon, the ascending colon part of it, part of the transverse colon, and the pylorus part of the stomach. So even though you don't have an entire organ for all of them, some of them go into the different other quadrants. So key examination steps for the abdominal region: you want to inspect, auscultate, percuss, and then palpate. So that just needs to be switched. Inspect for scar, stripe, TKI, spider angiomas. Observe the contour for symmetry and distension. Shifting with position changes. Observe the density and pattern of pubic hair. Inspect the genitals for redness, swelling, lesions, any discharge. Inspect the anal areas for lesions and hemorrhoids, fissures. Perform a digital rectal exam, auscultate for bowel sounds, auscultate for rubs and vascular sounds, and percuss the abdominal wall. So inspection is the first thing we're going to do. You're going to place the patient in the supine position, and this is where you're going to assess for the abdominal contour. You're going to note the shape of the umbilicus as an innie, as an outie, any hair density, and you're going to check for an umbilical hernia or an incisional hernia. You want to ask the patient to raise his head and shoulders while remaining supine, and a true hernia will protrude during that maneuver. So a 49-year-old Caucasian female presents with a 3-day history of intermittent epigastric and right upper quadrant pain, which has increased in intensity over the last 4 hours. Currently, she's experiencing nausea and vomiting. She feels warm and denies chills or an upper respiratory infection. So the first thing you have to think about is what organs are in the epigastric region and in the upper right upper quadrant region. So if we go back to this, in the right upper quadrant region, I had already mentioned what was in there. So you have part of your liver, your gallbladder, your duodenum, your pancreas, your right kidney, part of the kidney, right adrenal gland, hepatic flexure, part of your colon, and your stomach. So those are things that you're going to think about. So if that's in my right upper quadrant, in the epigastric area, what do I need to really check for? So the questions that you're going to ask, and you think about the questions you need to ask your patients. Is the pain sudden or gradual? So remember, sudden severe pain that awakens a patient from sleep can be associated with acute perforation, inflammation, or torsion of any abdominal organs. You also want to do your location. Describe the location and radiation of pain. Location at onset and localization and radiation are clues to the cause of pain. So remember, you're going to do your OCART, you're going to do your PQRST. So as you're doing this, jot down what other questions that you're going to ask that you want to know, and what are the functional assessments that you really want to look at and do. So the things you're going to look at for this patient is location, description of the pain associated with the GI disease. So you have appendicitis. Usually it's periumbilical, so it starts usually underneath the belly button or in the epigastric region. Sometimes it can start there. As colicky, then localizes to the right lower quadrant. It's usually most common in patients between the ages of 10 and 30. That's not to say if you're 60 you can't get it, because you can, but that's usually more common between the other ages. It's usually a sharp pain in the lower right abdomen that occurs when the area is pressed on and then the pressure is quickly released. That's a rebound tenderness. And pain that worsens with cough, walking, or other jarring movements. The other thing you can do is have the patient stand up, have them stand up on their tippy toes, and then drop down real fast on their heels. If they get a jarring pain there, that could be an example of an appendicitis or a peritonitis. Cholecystitis is a severe epigastric or right upper quadrant pain that can be referred to the shoulder. A positive Murphy sign is seen in acute cholecystitis. It's elicited by firmly placing a hand at the costal margin of the right upper abdominal quadrant and asking the patient to breathe in deeply. And if the gallbladder is inflamed, that's, as you push in and the patient takes a deep breath, it pushes the gallbladder down, descends so that it comes in contact with your hand, and they'll experience pain. They'll actually stop that breath because the pain is too much. So that's usually a positive Murphy sign. Diverticulitis is an epigastric pain that radiates to the left side of the abdomen, especially after eating. Intestinal obstruction is the severe, abrupt spasm-like pain that's referred to the umbilicus, and the epigastrium is often described as gripping. Leaking abdominal aneurysm, it's a steady throbbing pain over the aneurysm that may radiate to the back or the flank. It's also usually described as tearing. It's usually a very, very severe pain. Pancreatitis is an acute excruciating left upper quadrant pain, usually in the umbilical or epigastric pain that can be referred to the flank and the left shoulder. Pain is can be really, really severe. Patients could pass out. Usually the pain will come after somebody eats because the pancreas is so inflamed that when they eat, it stimulates the pancreas to secrete the enzymes to break down the food, and that's when you end up with the pain. So usually they'll get a lot of pain after. That's why when they're put in the hospital, they're usually in PO until they can get it situated. Perforated gastric or duodenal ulcer, abrupt right lower quadrant pain that may refer to the shoulder. It's usually described as burning. Ruptured abdominal organ pain is felt all over the abdomen. There's usually no localization. And biliary stones it's an intense pain in the right upper quadrant. It's usually described as cramping. Then you have kidney stones or renal calculi. The pain is described as excruciating and often begins in the back or the flank of the side of the low back, and it can radiate to the front of the abdominal wall. In males, it can cause testicular or scrotal pain, and the pain is often intermittent in waves. It can be associated with nausea, vomiting, and sweating. The intense pain can be continuous. It can wax and wane, and oftentimes, as the stone travels, the pain will travel with it, and usually goes toward the bladder, so it goes into the groin area. Often in between the intense phase, there remains a dull ache, usually in the back or the flank area. And once the stone passes into the bladder, the obstruction is usually relieved and the pain generally resolves. However, the dull flank ache that was there oftentimes will remain for a few hours or days after the stone is passed. Now you have to qualify the patient's pain, visceral pain. Usually when a hollow organ such as the stomach or colon forcibly contract or become distended. Solid organs such as liver or spleen can also have this type of pain when they swell against their capsules. And this type of pain is usually like a gnawing, cramping, or an aching pain. It's often difficult to localize, such as a hepatitis. Parietal pain, the pain occurs when there is inflammation from the hollow or solid organ that affects the parietal peritoneum, and this type of pain is more severe and usually easily localized, such as an appendicitis. And referred pain is pain that originates at different sites but shares innervation from the same spinal level, such as the gallbladder. Oftentimes you'll get pain in the shoulder. And the other thing you want to look at is other associated symptoms that might be there, such as fever, nausea, or vomiting, diaphoresis. This is a good picture for pain by abdominal areas. And I'll let you read it, but it shows you, if you have right upper quadrant pain or epigastric pain, you get pain from the biliary tree. So this shows you all different ones. So just look at that. It's really a good picture. So questions that you need to ask the patient. You're going to ask them to describe the pain in their own words. You don't want to throw adjectives out to them. You want to say to them, you tell me about the pain. You want to hear them say that it's annoying pain, it's aching, it's severe, it's sharp, whatever. So you want them to tell you. You want them to point to the area where the pain is. Especially the pain, the worst pain is a lot of times you can ask them. Then you're going to ask them if it radiates, but you can ask them to point to the specific area. Ask about the severity on the scale of 1 to 10. Ask about what brings the pain on. Ask them how often the pain occurs. Is it a constant pain? Is it just occurring daily? Is it occurring nightly? Does it occur after they eat? After they move the bowels? What? So you want to know the frequency and the timing. Ask them how long the pain lasts. Does it last for 2 seconds? Does it last for 5 minutes? Has it been lasting for 3 hours? Did it last all day? Ask if the pain goes anywhere else, such as radiation, and ask if anything aggravates the pain or relieves it, such as position changes, certain foods. Ask about any symptoms associated with the pain. Ask them how is their appetite? Are they able to eat? Any symptoms of the following: heartburn, which is a burning sensation in the epigastric area radiating into the throat. It's often associated with regurgitation. Excessive gas or flightus leading to belch or past gas. Patients often state they feel bloated. Do they have abdominal fullness? Do they eat a little and they're full? Anorexia, lack of appetite. Regurgitation, the reflux of food and stomach acid back into the mouth, usually will cause like a brine-like taste. Vomiting or retching, there's usually a spasmodic movement of the chest and diaphragm. Like vomiting, but no stomach contents are passed. Ask about the amount of vomit. What type? Is it food? Was it green or yellow? Was it bile colored? Was it mucus? Was there blood in it or coffee grounds? Ask about the bowel movements, the frequency of them, consistency, such as diarrhea versus constipation. And has things changed? Did they used to go every day? Now they're going every 3 or 4 days. They used to go every 3 or 4 days, and now they're going 2 or 3 times a day. So those are the things that you want to ask them. Any pain, any blood or black tartar stools. Ask about the color of the stools. White or gray color is indicative of gallbladder disease. Dark black, bleeding from high in the GI tract. Red blood is usually lower in the GI tract. So dark one is because it's higher up, it's taking longer to go, so it's older blood. Whereas when it's lower, it's more bright and more frank. Look for associated signs such as jaundice or scleral icterus, because those can be associated with your hepatitis or some kind of liver obstruction. Ask about frequency of urination and urgency. Do they feel like they need to urinate, but they're going in there? It's very little amount is coming out. Ask them about any pain, burning at the urethra, or aching in the suprapubic area. Just remember, women who have UTIs, oftentimes they don't necessarily have dysuria. Usually they'll have frequency, and oftentimes they'll have low back pain, which would be associated with the UTI. Ask about the color and smell of the urine. Red urine usually means hematuria. You also have to ask them if they've eaten anything recently that could change the color of the urine. Ask about difficulty starting the stream, especially in men. especially in older men, if they have problems with their prostate, so they might have trouble starting the stream, they might have trouble keeping it going, they might have a weak stream. Ask them about leakage, and sometimes when they get older, they dribble. Women might have stress incontinence. Ask about back pain, because not only can that be a sign of a UTI, but if they have a positive costovertebral angle, positive CVA, when you check it, could be a pyelonephritis. And in lower back in men can also be referred pain from the prostate. So in men, ask about symptoms in the genital area also. Ask about medical problems related to the abdomen, such as hepatitis, cirrhosis, gallbladder problems, pancreatitis, or diverticulitis. In women, ask about pregnancy and the date of the last menses, character of the menses, if they use contraception and what kind. Because a displaced IUD can present with abdominal pain as well as a ruptured tubal pregnancy. Ask about prior surgeries of the abdomen because you can get adhesions which can cause pain. Ask about any foreign travel, occupational hazards, contaminated food or water that they may have come in contact with, tobacco, alcohol, illegal drugs, medication history. Ask about hereditary disorders affecting the abdomen in the history of the patient's family. Ask about family history. You want to know about any colon cancer, ulcerative colitis, history of Crohn's disease, anything like that. Inspect the abdomen. Again, you're going to look at the skin, so you're going to look at scars, striae, which are stretch marks, vein pattern, hair distribution, rashes, or lesions. Look at the umbilicus, observe the contour and location and any signs of the umbilical hernia. Look at the contour of the abdomen. Is it flat, rounded, protuberant, scaphoid? Is the abdomen symmetrical? So is it a totally flat abdomen, or is one side a little higher than the other? Inspect for signs of peristalsis. If somebody's really thin, a lot of times you can actually see the peristalsis in the abdomen. You can see the pulsations. And if they have in their aorta, sometimes you can see the pulsations of the aorta. You can even see the PMI if somebody's thin enough. Okay, so when the patient presents with abdominal pain, the exam must be tailored to allow a detailed exam while causing the least amount of pain possible. So before beginning, ask the patient to tell you where the pain is most intense, and then you want to start at the quadrant diagonally from the area that's identified. You want to save the quadrant that's causing the most trouble. You want to save it last. So the physical exam of the abdomen, so the order that you do it is you're going to inspect, auscultate, percuss, and palpate. Okay? Always auscultate before palpating or percussing the abdomen, because if you don't, it's going to get things going. And, if somebody had hypobowel sounds and you started percussing and palpating, you might get them going. So you wouldn't get an accurate reading. Place the diaphragm over the abdomen to hear the bowel sounds, which are long gurgles that you hear. They're transmitted across the abdomen. So it's not really necessary to listen at multiple places. However, I always listen in the 4 areas. And the normal frequency of sound is 5 to 34 seconds per minute. Place the diaphragm over the aorta and the iliac arteries because you want to assess for bruits. And those are vascular sounds resembling whooshing. Remember, it's the blood trying to get past an obstruction. And place the diaphragm over the liver, the spleen, because you want to listen for a friction rub. Abdominal inspection, you want to stand to the right of the patient, help the patient to the supine position. You want to make sure that you adequately expose the abdomen without totally exposing the patient. Tell the patient what you're going to do before you do it. These are just different shapes of the abdomen. So you have your scaphoid, you have your flat, and you have your rounded or protuberant. And sometimes protuberant can be even bigger than that. Okay, so again, your abdominal extension, you contour your scaphoid, which is hollowed, abdomen is flat and rounded. Other descriptors, you have distended when the abnormal state of inflation is detected. Protuberant, the abdomen is thrusting forward in a more solid fashion, so you have one that's large, around it, but the protuberance is really big. General symmetry, is it, like I said before, does it look symmetrical on both sides, or is one higher than the other? Visible masses, skins for lesions, scars, and striae. You always want to look for those. Caput medusa is observed for dilated veins around the umbilicus called caput medusa, suggests portal hypertension, and is often associated with cirrhosis of the liver. So this is just a cartoon picture up here, but the one on lower here shows an actual abdomen that has it. You want to inspect for peristalsis. Like I said, if somebody's really thin, sometimes you can see the waves as they travel down the colon. Ask the patient to bend forward, as if doing so to sit up increases the intra-abdominal pressure and may reveal hernias or rectus diathesis, which is the separation of the rectus abdominis muscles, central linear bulging. I've seen hernias with that, but nothing else. Two forms of intestinal obstruction. You have mechanical bowel obstruction and paralytic ileus. In an infant and toddler up to 2 years old, intussusception is the leading cause of intestinal obstruction. That's when a part of the intestine turns like a thimble against itself. At older ages, this is rare. Intestinal obstruction is a medical emergency that requires immediate care. In most cases, surgery is needed to relieve the obstruction and avoid any necrosis of too much of the intestine. You can get a partial intestinal obstruction. You can get a total. Sometimes certain medications will slow down, like your narcotics, will really slow down the peristalsis. So you have to really make sure those people are on bowel meds, give them the power pudding, all different things to make sure that you keep their bowels going. They drink plenty of fluids. Percussion, you want to percuss over all four quadrants, listening for tympany, which is a hollow sound, versus dullness, which could be large amount of stool or a mass. Percuss over the liver in both the midclavicular line and the midsternal line. When you percuss for the midclavicular line, it should be 6 to 12 centimeters. It's an important thing to remember. Longer than that indicates a swollen and large liver. Mediastinal line percussion should be 4 to 8 centimeters. Shorter than this can indicate a small hard cirrhotic liver. Percussion, air creates dull-like resonance, whereas liquids and solids are dull on percussion. Resonance is increased in areas where intestinal gas is collected, commonly the gastric air bubble, and over the transverse and descending colon. Solid organs, masses, stool-filled bowel, and intra-abdominal fluid collections percuss with dullness. So you want to percuss over each of the four quadrants. At the bottom of some of these slides are YouTube sites to go to watch. Actually, they're very good, so you really should listen to them and watch them because they really go over how to do a lot of these percussion and palpation maneuvers. Physical exam of the abdomen and percussion. To percuss the spleen, there's two different ways you can do it. One, you can percuss the left lower anterior chest wall between the lung, resonance above the costal margin. Dullness indicates it in the large spleen, while tympany is usually prominent and means that the spleen is fine. Or you can check for the splenic percussion sign. Percuss the lowest interspace in the left anterior axillary line, and the area is usually tympanic. Then have the patient take a deep breath and percuss again, and if the spleen is a normal size, the percussion remains tympanic. Shifting from tympany to dullness with inspiration suggests an enlarged spleen, and that would be a positive splenic percussion sign. And again, there's a YouTube site for that. Percussion of the liver. You want to begin superiorly by percussing at approximately the fifth right intercostal space in the midclavicular line. And you want to move caudate towards the feet, 1 centimeter at a time, until hyperresonance of the air-filled lung becomes dull at the top margin of the liver. Auscultation. Always perform before palpation to allow for proper assessment of bowel sounds, which can be altered by any palpation. All four quadrants should be assessed. The result of peristalsis, where the contents of the bowel are being moved to the alimentary tract, produces intermittent clicks and gurgles. We've all heard them. And like I said earlier, usually bowel sound is usually from 5 to 34 seconds per minute is a normal active. The familiar audible rumbling, gurgling sound of air passage through the large bowel, and it's also part of everyday sounds of healthy bowel function. So your hypoactive is bowel sounds are not quickly appreciated, auscultate for up to 2 minutes. It's usually found with an ileus or paralysis of the bowel and peritonitis. Absent bowel sounds could indicate ischemic or infarcted bowel, and hyperactive bowel sounds are greater than 34 per minute, irritation, infection, or inflammation of the bowel. When you hear a high-pitched tinkling sound, it's reminiscent of a fountain. They're found, it's usually found with bowel obstruction. Vascular sounds. So you're going to listen for bruits. And bruits can be caused by cirrhosis or renal artery stenosis. A hepatic bruit is indicative of alcoholic hepatitis or primary or metastatic cancer. And remember, a bruit is the sound that blood makes as it's trying to get past an obstruction. Next is the liver venous hum. It's the presence of an abdominal venous hum is diagnostic, usually of portal vein hypertension. It's usually secondary to cirrhosis. And then the friction rub. If you feel a thrill, remember you always feel a thrill and you listen for a bruit. So if there's a thrill present, usually there's a friction rub will be heard. A hepatic friction rub sounds close to the ear when you rub your two fingers together and you ask the person if they can hear it. That's usually what it'll sound like. And a hepatic friction rub in the liver is indicative of the liver with inflammation. It can be also indicative of cancer. In changes or infection. Let's see. For capitis medusa, when we talked about that, the veins on the outside of the abdomen, like I said, those are varicose veins. They usually radiate from the umbilicus. And if present, that you want to lightly palpate them. To see if you can feel a thrill. If a thrill is present, a venous hum is usually present, like I said before. A hum is listened to by light pressure of the stethoscope. So you only want to put it gently on the abdomen or on the varicose veins if you see them, only gently to listen. So in summary, you first auscultate the 4 quadrants of the abdomen for bowel sounds, assess the aorta, the renal arteries, the iliac, and the femoral arteries for bruits, and auscultate the right upper quadrant for a venous hum. Palpation is performed with the provider sitting on the right side. You want to start with light palpation, and then you go to deep palpation. Light palpation is completed first with the provider placing one hand flatly against the abdomen and using the pads of the fingers, moving in a circular motion to feel the skin and only go as far as the subcutaneous tissue for tenderness and masses. You want to consistently watch the patient's face for grimacing or flinching for signs of any pain or discomfort during the exam and assess all 4 quadrants. This is just an example of light abdominal palpation, how it's performed. And again, you only want to go as deep as the subcutaneous tissue to the muscle. You don't want to go any deeper than that. You don't want to go down past that. After you perform light palpation, then you can go to deep. Apprehension, the fear that the provider's palpation of the abdomen will cause pain can be encountered. So you want to tell them what you're going to do before you do it. If the abdomen is profoundly tender, such as with peritonitis, the patient may exhibit guarding, which are involuntary movements to stop the examiner from pressing. They'll tighten up their muscles and they'll be rock hard so that you can't even press down on it. So to perform with slow, deliberate, cautious technique, keeping the hand flat to disperse the applied pressure, you want to avoid jabbing or poking with just your fingertips, and complete by placing one hand on top of the other. The top hand applies pressure to the lower one in a rolling motion, kneading the hand deeply into the abdomen with deliberate screening of each quadrant. You want to envision palpating with the intent of locating the intra-abdominal organs and muscles. And again, you need to visualize in your mind what is there and what you should be feeling. And if you should be feeling things, the spleen you shouldn't usually feel when you check for it. So if you do, that's something that you would have to look further into. As you approach each quadrant, again, think about what organs are there. This is just an example of showing you how to do deep palpation. Okay, now if the abdominal wall is too tense to allow for easy palpation, it may be helpful to have the patient bend their knees to 90 degrees, flexing the hips and placing the feet flat on the exam table. It takes the tension off the rectus muscles, and sometimes that'll make it easier to palpate. And if somebody's really large, sometimes that can be really hard to palpate because there's so much adipose tissue that you have to go through to palpate that sometimes it makes it difficult. When you palpate the liver, the border can be just palpable below the costal margin. Enlargement greater than this is considered hepatomegaly or large liver. Using one hand, you want to begin the palpation in the right lower quadrant with the hand placed perpendicular to the midclavicular line. This shows you a picture right here. You want to roll the hand from the ulnar to the radial aspect, depressing the abdomen approximately 5 to 10 centimeters. After each roll, you want to slide the hand 1 centimeter up toward the head, staying in the midclavicular line. You want to repeat that until encountering the liver border or the costal margin. Again, here's another YouTube site that you can go to. So when you go to clinical, these are the things that you want to try to do. So when you have your physical exams, patients coming in with abdominal discomfort, whatever, these are the different techniques you want to use. When you palpate the spleen, you're going to use the same rolling technique. You can have a line of approach. You begin at the umbilicus and move diagonally across the lower upper the left upper quadrant of the inferior costal margin. You want to place the left hand behind the left lower ribs. Lifting may help to displace the spleen toward palpating the right hand. It's not usually palpable unless it's enlarged. And again, this shows you pictures on how to palpate it. Kidney. A kidney catch is performed by placing one hand behind the costovertebral angle and the other hand just below the anterior costal margin. Ask the patient to take a deep breath with the intent of the diaphragm displacing the kidney cauded towards up and towards the feet. At the end of deep inspiration, you want to apply pressure between the two hands in an attempt to catch the kidney. Instance of AAA, abdominal aortic aneurysm, rises with age in the 60s and a history of smoking, especially in older men. It's more common in them. So that's why they guidelines say that if you have an older man in his 60s that smokes, that you should do a CT scan at least once to check for an abdominal aneurysm. Commonly asymptomatic until it either dissects or ruptures, or it gets so large that it impinges on the other organs and starts causing trouble. Bifurcate, usually most commonly found below the renal arteries. You want to place, bifurcates approximately at the umbilicus. You want to place both sides in the lower half of the area between the umbilicus and the xiphoid, with the hands approximately 5 centimeters from midline on each side and the fingers pointing toward the patient's head. You want to do slow, deep pressure as applied. and you just want to palpate the wall of the aorta. If no beat is felt, you want to lift the hand slightly and move each medially 1 centimeter, and then depress again until you can feel it. And then you want to estimate the width. Percussion of the liver span. Note the level either by a natural landmark or you can make a mark with a pen. Then move inferiorly to the level of the umbilicus and begin percussing towards the head, staying in the midclavicular line. Again, here's a YouTube note that tells you how to check for the resonance. Air-filled bowel becomes when it's dull, reaching the inferior margin of the liver. In the adult, the liver border is typically not palpable. Expect the liver border to be percussed above the costal margin, and when locating the inferior edge of the liver, you want to mark the level. So then you measure the 2 marks. And again, the normal liver span is approximately 6 to 12 centimeters in the midclavicular line. Bladder height percussion can also be used to find the height of the bladder in a patient who's having problems voiding. Bladder distension secondary to lower urinary tract obstruction can be painful, so you need to be careful. Percussion should be performed as gently as possible, starting below the xiphoid process and moving down the midline to the pubic symphysis. Dullness to percussion is encountered at the dome of the bladder. You want to measure enlargement in centimeters from the dome to the top of the pubic symphysis. And remember, a normal bladder, even a full state, is not typically palpable or percussible. The acute abdomen refers to a sudden onset of pain, typically within the prior 24 hours, and is a term often used synonymously with peritonitis, a ruptured viscus such as appendicitis, gallbladder, ulcer, or diverticulum. There's often rigidity and rebound tenderness. In rigidity, the patient often exhibits guarding and severe irritation of the peritoneum that can result in rigidity. The abdominal muscles become board-like. Even though the patient tries to relax their abdomen, every time they know you're going to touch it or the pain, it just gets really rock hard. The abdomen may feel hot to touch, and the patient may flex into the fetal position to decrease stretching of the abdominal wall. Rebound tenderness is used to check for irritation of the peritoneum. You want to advise the patient that you must touch their abdomen, and you want them to tell you when they have pain. Is it when you're pushing down on the abdomen or when you're letting go? When you lay your hands on the abdomen and you slowly push down as the patient tolerates, ask the patient, which hurts most? Am I pushing now or when I let go? And then quickly lift your hand, jarring the peritoneum. Pain suggests when you're lifting, that's a positive rebound tenderness, and it suggests a peritonitis. It can also be suggestive of appendicitis. Appendicitis, you have the Rovsing sign. If the patient has a right lower quadrant pain and appendicitis is in the differential, then you want to check this for the sign. And what you do is you slowly but firmly press down on the left lower quadrant, asking the patient if it causes pain again or worsens the pain. If so, if it does cause pain or it really worsens pain, that's a positive sign and it increases the probability of appendicitis. The psoas sign helps locate the appendix if it's in the retrocecal anatomic location. In this case, the appendix lies on top of the sheath of the psoas muscle, causing increasing irritation as the perforation progresses. With the patient in a supine position, the provider places a hand just above the patient's right knee and asks him or her to lift the leg off the table. This will cause the iliopsoas muscle group to contract, moving the inflamed sheath of the appendix, causing pain in the retrocecal position, and that's a positive psoas sign. An alternative would be to have the patient in supine position lying close to the edge of the exam table, and you can lower the leg slowly off the table, stretching the psoas muscle with passive hip extension, which would also cause pain if there was an appendicitis. And this is just a picture of the demonstration of the psoas sign. The obturator sign is also used in appendicitis, and it's used to detect an inflamed appendix which lies against the obturator muscle. When the patient in the supine position, the provider holds the right leg by the ankle, flexes the knee with the other hand along the lateral margin of the knee, and at 90 degrees of hip flexion, the provider internally rotates the hip. This motion will move the obturator muscle, causing pain if the appendix is located at the muscle. a positive obturator sign. You can also have both a positive and a psoas and an obturator sign at the same time. And this is just a picture of that sign, of doing the sign. Cholecystitis, you have mercury sign. You have suspected right upper quadrant pain. Place the right hand on the abdomen with the fingers parallel to or just below the midclavicular line. Ask the patient to let out a breath and then slowly depress several inches. The palpating hand is held still, then you ask the patient to take a deep breath in. And again, like I said, when they take a deep breath, the diaphragm moves down. It moves the liver and the gallbladder down towards the provider's hand, causing the pain. So they'll stop that breath because it hurts too much. Okay, and again, this is a YouTube site that you can go to watch them do that. Ascites, in a patient with cirrhosis or heart failure, the abdomen should be assessed for ascites, which is the accumulation of fluid in the abdominal cavity. It may be evident with flank bulging, but may be more difficult to differentiate from adipose in patients who have really large abdomens. There's two methods you can do, the fluid wave test and the shifting dullness test. In the fluid wave test, what you can do is you can have the patient or an assistant, if you have them, place the ulnar aspect of the hand on the midline of the abdomen and depress 2 to 3 centimeters. Place one hand laterally on each side of the abdomen, then tap sharply on one side while holding the other hand firmly on the opposite side. If ascites is present, the fluid wave moves under the hand in midline and the impulse is felt in your opposite hand. With adipose, the impulse created from the tap stops with the hand placed midline. If the abdomen for shifting dullness, if the abdomen contains ascites, the principle of gravity dictates that it will pull toward the patient's back if in the supine position. You want to begin percussion at the umbilicus and note the amount of tympany. Working from the umbilicus, you want to percuss laterally toward the flanks, moving 2 to 3 centimeters with each step. The umbilical area will be resonant with air accumulation superiorly, while dullness will be encountered when the upper level of pooled fluid is reached. So you want to mark that level. And this just shows you how to do that. Also, you want to remember when you percuss onto your middle finger. That's the only finger that you want on the abdomen. You don't want your whole hand on the abdomen, just that middle finger. And then you use the middle finger of your other hand to tap it. You could also use a reflex hammer if you don't want to use your finger to tap your finger. And then you want to listen to your sounds. You should practice it. Practice it over your thigh, over your chest and your abdomen, and that way you can hear the different sounds over your belly. So again, for shifting dullness, you're going to continue. You're going to ask the patient to roll on their side. If fluid is present, it will now shift to the side against the table while the air will move to the opposite superior side. And you're going to repeat your percussion, this time starting at the patient's superior side and working toward the table. And then again, you're going to mark where the dullness is. And then if free fluid is encountered, the dullness will shift from the first mark to the second mark, shifting your dullness. And this is just, again, pictures that show you how to do that. And ascites is detected when the level of the dullness shifts location. So this shows you the levels, the shifting of it. Hydronephrosis and pyelonephrosis, Lloyd's punch, you perform to assess for CVA tenderness. It can cause intense pain if performed too aggressively. Palpate each CVA for tenderness first with light and then with deep pressure. So when I do a tap, I always do it lightly on each side. If there's nothing, then usually if somebody has a pyelonephritis or a hydronephrosis, just a light tap will cause them pain. So if it's not causing them pain, I don't usually do a harder tap. But you can, if it's tolerated, then you can just thump them a little harder. Distension of the kidney capsule, the presence of inflammation will cause the patient to experience pain and often jump when struck. I've had patients that really, they yelled and they did jump when I did it because it really hurt. And they did have a pyelonephritis. But usually I do it and they don't even make a sound. Okay, so that's the end of this lecture. It was a really long one, I know, but the abdomen is so vast. There's so many things that can go wrong into it. So remember to read your chapters. Go through all the YouTubes because it'll show you how to do things. Practice them at your clinical site because you have somebody right there who has the experience and they can help you to do them correctly. Read the articles. I already have the PowerPoint to this is already in under this week's sessions. Under I think it's called the Abdominal Class WIMBA, something like that. So it's already in there. If you need me to send it to you, just let me know. But you should be able to download it from there. And then next week we'll go over skin, and then the following week we'll have the test. So thank you very much.